Good morning. Thank you for joining us today. If you're on this call, you are a leader from a community service board in some capacity. Hopefully, we have CEOs, possibly CFOs, COOs, clinical directors, or board members. Thank you for taking the time to join us today. We're excited to introduce to you all a project that we are working on. I've had the honor and fortune, I would say, of being with the department. It'll be 10 years in November. I feel like I've been saying that a lot lately. 10 years goes by really fast. And in that time period, I've had now, this would be my second opportunity to partner with MTM. We've done this work in some capacity before, and for those of you that like to connect the dots, hopefully as this conversation today unfolds, you'll be able to do that. We've partnered with MTM before when we look at how can we advance, make improvements, and keep our community behavioral health system and our network moving forward. And so as the division director for behavioral health, I am just honored to be here today to talk about what's ahead while we are currently in some definite unpredictable and unprecedented times. We're still future forward looking. And so it's just a great privilege today to be with you. I hope that today you get a good feel for what's coming up and get an opportunity to ask some questions. And for those that don't know me, I think I may have even skipped. I'm Monica Johnson, the Division for Behavioral Health here at the department, and one of the main project managers for this work. So with that, I'm going to turn it over to our esteemed Commissioner Fitzgerald for some opening comments.
All right, let's try again. Good morning, everybody. Now you can hear me. I'm so glad to have all of you with us. Monica's acknowledged the broad array of CSB leadership and I think probably association partners that we have on the line. And I'm glad to be with you in the way that people are together right now, the safe way people are together, which is across a screen. And I really want to start out just by saying that first and foremost, I hope that you, your staff, and your loved ones are healthy. And I hope that you're finding ways to take care of yourselves. Each of you and each of us, everybody on this line, has big responsibilities as Georgia Safety Net leaders. And I want to make sure you're together with us for the marathon ahead. So. And the work doesn't stop. So it's really important to practice self-care and know that we support you in doing that. And here we are with the work going forward. Today is really about acknowledging that both despite the challenges that we face and because of the challenges that we face, we are going to have to continue on the path of progress for Georgia Safety Net. So as Monica mentioned, the last time we partnered with MTM, it introduced a really fundamental change to our network. You all are, many of you, most of you were a part of that. You had input and really assisted with a thoughtful redesign. And that's how I want you to think about MTM again. As we all say, when we bring in MTM, we mean business. And so we mean business about making more progress with your help. And we bring in MTM because we respect the experience that they have from other states, which is immense, as you all know, and you will continue to see. But we also respect how much they know about Georgia and, frankly, how much they deeply care about what happens in Georgia. They've been great partners. I'm glad you're going to have an opportunity to hear from them this morning. As we think about this next step for how to move Georgia Safety Net forward by anchoring to the CCBHC model. And you keep hearing me use my term safety net. I want to clarify and make sure everybody on the line knows what I mean when I say that, and we've had a lot of discussion about that. But when I say Georgia's public safety net, I'm talking about DBHDD's hospitals, our crisis system, including GCAL, and our CSBs. You all have a critical role to play in the state. I hope what you'll reflect, actually, I'm glad Monica mentioned her anniversary. Jeff and I celebrated an anniversary yesterday as well. It's been 8 years since we came to the department. When I said I'd only stay a year, so not all things come true. I'm really, really privileged to have the opportunity. Since we came in with Commissioner Berry, we made a commitment to all of you about a top goal of ours was to preserve the network. And I hope that you believe that every step we take is in the interest of trying to preserve our safety net network. So now, as we face what I think is probably the most challenging time of our professional careers, with the responsibilities before us, our plans to partner with MTM to really move us toward the CCBHC model, those plans which were in place before COVID have emerged as more important than ever now in the face of COVID. We need to be ahead of the curve. We need to be dictating our future here in Georgia. Because of the budget and because of COVID, we know that our work is going to be scrutinized more than ever. And we want to take every step we can, not only to preserve the safety net, but to fulfill our commitment to make sure that the safety net is consistent, accountable, standardized, transparent, and most importantly now, aligned with national models of care as evidenced by the CCBHC. And I want to remind my Georgia partners, we talked about this a little bit last year, there's a parallel here. In the last year or two, there's been a lot of emphasis and scrutiny on the role of rural hospitals. And they really elevated as becoming protected as a state asset. You know, in many ways, this is what we want as well. We want to be recognized as a state asset. There's a trade-off that occurs when we do that. We say we want to be a state asset, then what's critical is that we bring transparency of our operations and our finances and our governance to the way we do business. And we're excited to bring a pathway to do that. We are eager to walk this path together with you, and we're going to be far more successful if we're in this together. That's why we're starting out in conversation. We're letting you see everything that we've learned about what MTM is bringing to us from their experience in other states. It will become very clear why the CCBHC model is the pathway forward. I had an opportunity to directly ask Assistant Secretary McCants-Katz about the future of the CCBHC model, and she absolutely doubled down and said, this is where the feds are going to continue to invest. This is the path we need to be on. Now, we've got one tweak, and one thing we recognize in Georgia, that model doesn't account for our individuals with intellectual and developmental disabilities in a way that we'd like to. So that's part of how we're going to bring a Georgia flair to a national model, and there'll be a lot of work to be done around that. But today is the day to begin the conversation and embrace the opportunity ahead. So I'm really excited to be with you in order to do this. As we begin this work together, I want to make one final reflection and remark about something that you all have done remarkably well for so many years. I want your boards to hear it. I want the CEOs and other leaders to hear what we know is that you have made yourselves, in so many cases, beloved and vital and essential in your local communities. Thank you. I hear about that all the time, and maybe we don't tell you enough about the many ways we hear about that. We do hear about it. I hear about it when it doesn't happen, but more often I hear about it and we know about it when it does. That's really, really important. I really appreciate the ways in which you embrace the mission to serve your local community, even when at times it seems like the needs are too great. We don't want to lose that. We don't want to lose the local knowledge and the local impact that you have as we inch towards this new model. Only you can meet the local need. By the same token, I want to remind you what the state office's responsibility is. And ours is to act on behalf of the whole state. I anticipate that as we walk this next path together, we're going to have difficult decisions that we have to make. As you know, as we've demonstrated in many cases already, we are going to act to preserve the network. We're going to do everything we can to make sure that CSBs are viable and vital. That means we're in this together. You don't need a slogan from me to get this underway, but I want to take responsibility for one thing. I've asked you all repeatedly over the last couple of years to think like a network and act like a network. I think this movement towards CCBHC is going to help us to do that. And it's my observation that practically speaking, you're at your best when you are seeing and knowing your local impact. We're going to ask you to keep reflecting on what's the local impact of changes that we make. We want to keep hearing your perspective. In fact, you've asked repeatedly to be involved early and often. And what I want to invite you to do is know that the best way for you to have influence and to be involved is to share your information with MTM in a timely and transparent fashion. That's the best way for you to ensure that we see what's happening for you locally. But it's important for me to draw a line and make clear about your role and about ours. Your role at the local level is so vital. We can't do what you're doing. By the same token, it's my expectation about what DBHDD will do. When we ask you what changes might mean for you locally, that's what we want to know. And then my team has to understand the differences in geography and workforce and history and funding history, and your board and your clinical leadership and other local resources. We want to hear about what's happening for you. It's going to be our role to determine what that means for what's in the best interest of the state. It's our role to take that information and operate on behalf of the whole. And the reality is, I just want to call it out here, in an underfunded system, which is what we have in the state of Georgia, sometimes when we make a decision at the local level, it will benefit you. And other times when we're acting on behalf of the network, it might not bear out that way for you at your local level. In the end, we are in this together. In the end, the goal is to make sure that we grow and secure Georgia's public mental health and substance use disorders safety net, and that we include individuals with intellectual and developmental disabilities in that work. We are so excited to proceed together with you. And here's my hope, that when we keep the people that we serve at the front and center of the work we do, that's when we're at our best together. And I look forward to seeing how a model that's out there for us to inch toward is going to be the most exciting opportunity that we've had in recent years. So very happy to be with you this morning and very happy to learn from MTM. I'll turn it back to you, Monica, and see if there's anything else we need to know before we hear from MTM.
Thank you, Commissioner. Thank you for your level of clarity and for your leadership. It is appreciated for certain by me and I'm sure others. I do have a couple of housekeeping things that I do want to make note of prior to turning it over to the MTM team. First, if you have questions throughout today's session, please feel free to use the chat function. We'll be monitoring that, and when we get to our formal Q&A section that will be available at the end of this meeting today, we'll go through those questions and try to field as many as we can on the spot. At the end, I'll also talk about mechanisms for how you can communicate related to project-related questions that need to come into the department. We'll talk about that at the end as next steps. But throughout the day's meeting, please feel free to use the chat function if you don't want to lose your thought or lose your question, and we'll be tracking those, and we'll do our best to try to address those by the end of today's meeting. And then second, I was asked by a participant, would we be recording the session for those who were unable to have someone that they wanted to participate, they were unable to come. So this webinar is being recorded. So it will be available for those that need it for other purposes. And with that, and seeing no other thoughts, it looks like, from the DBHCD panelists, then I will go ahead and turn this portion of the meeting over to Michael Flora from MTM to introduce himself, his team, and go ahead and do their presentation.
Thank you, Monica. Good morning, everybody. Thank you, Commissioner Fitzgerald. It's a pleasure to be working in the state of Georgia again. We really appreciate the opportunity to really partner with you and change the landscape in Georgia to really meet the national expectations. As Commissioner said, that CCBHC continues to be a growing model and a highly invested in model from the federal government. We're seeing that just even 2 more states were added to CCBHC in the last several weeks, with Kentucky and Michigan adding in to there. And we'll talk about what that means and the trajectory going forward. But before we get started, I'm Michael Flora with MTM Services. I'm their Senior Operations and Management Consultant. I've been with MTM Services about 20 years now, having had the pleasure of working not only with Monica in the state of Georgia, but all of you previously in our earlier work. But I'd also like to introduce some new members to the team that you may already know, Charlie Grantham and Joy Fruth. Joy, would you like to introduce yourself, please?
Yes, thank you. Good morning, everybody. My name is Joy Fruth. I'll be talking a little bit later about my role. I am with MTM Services, our same-day access lead. So I'm happy to be here with all of you, and thank you, Michael.
Thank you, Joy. Charlie?
Yes, thank you, Michael. And my name is Charlie Grantham. I'm the IT and process optimization consultant with MTM Services. I'm the geek in the room. So today we'll be talking about sort of some of that work and doing some IT and EHR baselining for your facilities. So I look forward to working with each one of you.
Thank you, Charlie. So let's go ahead and set the stage for our ongoing work of what we're thinking about and looking forward to, and kind of where this all began and how we got to where we're at. Part of that is understanding that under the Affordable Care Act and the Excellence in Mental Health Care Act, they coined the phrase Behavioral Health Care Center of Excellence. And if you recall, a Behavioral Health Care Center of Excellence is known by the entire community as a great place to work and a great place to get care. It's an organization or even a program within an organization that is an integral part of the healthcare neighborhood, providing rapid access to specialty behavioral health care services that include high-value, comprehensive whole-person care that supports resiliency and recovery and results in excellent outcomes and high customer satisfaction. With that in mind, there are 5 key elements that we look for. These will seem familiar as we move to CCBHC. Easy access. Can we get folks in the door today? Are there no delays? World-class customer service built on a culture of staff and client engagement and wellness, really moving towards that quadruple aim. Comprehensive care, being able to offer a full continuum of care. And that's where our work with you as you prepare for CCBHC and the expectation is we include individuals with intellectual and developmental disabilities, which is unique in the CCBHC world. Most CCBHCs are not incorporating that special population into the work they do. And so the work that we're carving out with you and planning for will include and be inclusive of those individuals. Excellent outcomes. Can we prove that we're getting better? Can we prove that clients are getting better? Really looking at those metrics, and we'll talk about the quality metrics that we must be able to provide, at least baseline. But we also have an opportunity to create those metrics ourselves. As we're currently not linked to SAMHSA, we have an opportunity to really look at what can we do, what are the building blocks to outcomes, and value. Remember, value is determined is can we provide the same or similar cost at the same or similar service at a lower possible cost that makes it a better value for the consumer and ultimately the payer and the communities that we serve. So what is the CCBHC? Well, in 2014, Congress passed the Protecting Access to Medicare Act. And as part of that, behavioral health clinics will have the federal definition and be defined as quality standards for reimbursement that reflects the actual cost of care. The legislation created a certification or criteria for CCBHC, or Certified Community Behavioral Health Clinics, as entities designated to serve individuals with serious mental illness and substance use disorders that provide intensive, person-centered, multidisciplinary, evidence-based screening, assessment, diagnostics, treatment, prevention, and wellness services. Our definition will also include those individuals with IDD. Certified community behavioral health clinics were credentialed and created through Section 223 of the Protecting Access to Medicare Act, or PAMA, which established a demonstration program. That demonstration program then led to additional organizations being certified as CCBHCs. The Excellence in Mental Health Care and Addiction demonstration established a federal definition of criteria for CCBHCs. These entities, a new provider type, and I think that's what we have to really think about ourselves, we're a new provider type, are designed to provide comprehensive range of mental health and substance use services to vulnerable individuals. In return, CCBHCs will receive an enhanced Medicaid reimbursement rate based on their anticipated cost of expanding services to meet the needs of those complex populations. Right now, there are more than 200 CCBHCs operating in 33 states. This includes 66 CCBHCs in the 8 states originally selected as part of the demonstration program, which was Minnesota, Missouri, Nevada, New York, Oklahoma, Oregon, and Pennsylvania. Since 2018, Congress has appropriated yearly funds for 2-year CCBHC expansion grants. 63 grantees, including 16 that were also original Medicaid demonstration participants, are currently operating in 21 states. So the growth of CCBHCs in April of 2020, the Substance Abuse and Mental Health Administration announced that these grants have been awarded to increase access to improve quality of community behavioral health care services. Fiscal year 2020 expansion grants included $200 million in annual appropriated funding and $250 million in emergency COVID funding. Certified community behavioral health clinics are leading a bold shift to increase access to quality behavioral health care services. The National Council of Community Behavioral Health Care is committed to creating 500 CCBHCs nationwide by 2025. When that happens, 2.9 million individuals will receive high-quality mental health and addiction treatment when they seek it, where they live, tailored to meet their specific needs. There are specific core elements that we look for in the new healthcare environment: governance and leadership. Our ability as organizations to really embrace and lead from a board and governance component as well as leadership, having the leadership to step through that threshold of risk. Access and intake and consumer screening, looking at our same-day access models, centralized scheduling, some of the things you already have in place in many of your CSBs, information and medical records management, our ability to connect through health information exchanges, RIOs, patient portals, the ease of use of our electronic health record, not only for those that we serve through patient portals, but also perhaps even our own clinicians, having the ability to click through and have ease of access, that the electronic health record is no longer a barrier to implementation. Workforce engagement and human resource management, really centering on that culture of staff wellness. We know that retention is a key issue across the country. So how do we help maintain individual engagement? Gallup has come out and said that 70% of the American workforce is not engaged. If our team members are not engaged, then they can't engage consumers. And so we know that when consumers are engaged, they complete episodes of care. And so really focusing on our workforce development and how we can help enhance and create opportunities. Billing and financial management and cost containment, looking at our back office, our revenue cycle, looking at some of the work that we've done and building upon that work for CCBHC, making sure that we're focusing only on scheduling those clients on appropriate credential panels. We're looking at our write-offs, our denials, our bad debt as an opportunity for increased revenue throughout our organizations. Strategic business planning and financial viability, being able to embrace and lean into the new opportunity of CCBHC as a strategic business plan. The key word there, team, is business planning. Our opportunity to really move forward with the metrics to drive our decisions. Safety and risk management, not only now in the middle of a pandemic, making sure that our consumers and our staff are safe and healthy, but also moving forward with both clinical and other financial risks that we're seeing. Continued quality improvement in corporate compliance. That continues to be a key element at the federal level, where the Office of the Inspector General still has behavioral health as a key element in their work plan for corporate compliance, but also looking at performance improvement, Based on our data, where do we move the needle to bend the cost curve? World-class customer service built on a culture of staff, client engagement, and wellness. So customer service will continue to be one of the key drivers in behavioral health care. Outreach and awareness. We need to make sure that individuals in your communities are aware of the services. They can access the services when they need them at their convenience. And all of this team centered around outcomes. Can we demonstrate that individuals are actually getting better? Can we prove the quality metrics? Because part of this is our strategic and effective clinical care as we looked at value-based payment, which is where this is going. You may recall some of the earlier discussions as we worked with you all in the initial core redesign of why don't we just go to value-based payments now? Well, fee-for-service is a step to value-based payments. We have to understand our cost of service. We have to know the episode of care. We have to focus on population health management, which requires us to look at risk stratification, which require us to look at care pathways that are administratively and clinically sound, and concepts that are not loosely linked but structurally contingent on one another, that we're deliberate in our workflows. As you can see, we've moved to fee-for-service, which has a high payer risk component. As we look toward value-based payments, the areas in red, bundled rates, stratified case rates, prospective payments, all of those have a level of shared risk, with some states already having moved to full capitation with full risk at the provider level, and what that means on a per member per month basis. We're seeing a combination now of fee-for-service with bonus payments in many states. We're seeing even Medicaid or managed Medicaid and the challenges we have with both CCBHC models and MCOs in those states, and we'll talk about that as we go forward in our technical assistance. So let's demonstrate that level of value, as we said, around customer service, the ability to provide excellent outcomes and excellent customer service, the service provided, timely access to care with a level of care benefit design, using evidence-based practices, and the screening requirements for CCBHC of the national outcome measures, the cost of services. What does it cost us to provide that service by CPT, HCPC, and provider type, the outcomes achieved, as well as value. Because value is determined based on, can you achieve the same or better outcomes of change in service delivered or change in service process cost, which makes the outcomes under the new clinical model a better value for the payer and ultimately the consumer. So our scope of work with DBHDD is to provide project management, facilitation, training, and consultation to assist with the assessment of their current system of care and the development of specific deliverables to prepare the department and its providers to become certified community behavioral health care clinics. So we have phase one, which is the process that we're in now. And consultation around this will consider around assessing the community service boards around to meet the SAMHSA's national certification standards for CCBHC. The phase will include forming state and provider level assessments of the 6 required certification program standards, costing and cost reporting systems, data collection and measurement standards, along with the creation of state strategic plan of action to address the areas uncovered during our phase one assessments. Phase one assessment will then drive us, based on the findings and recommendations of what we find, to a phase two implementation phase, providing technical assistance and readiness to bring everybody up to meet the standards and expectations. We have several phases as part of our timeline. We have the initial is kind of gap analysis and CCBHC certification readiness. That'll begin this month with all of you. State-level organizational strategic planning, which we've been working with Monica and the commissioner to kind of look at strategic planning and kind of get us to where we are today, along with an IT, electronic health record assessment that Charlie will be bringing in as part of our phase one. Phase two will begin in January. We hope to wrap up all of our work as part of this in a little more detail, a granular level of our milestones and project timelines. So today is our kickoff with all of you. Starting this week, we'd like to begin scheduling the gap analysis, IT assessments, and the CCBHC assessment. So each of us will be reaching out to you regarding our specific roles with you and getting things scheduled, not only for the gap analysis and the IT assessment with Joy and Charlie, but also I'll be sending you the readiness assessment tool for you to complete. On the 21st, we'll be looking at a CSB leadership survey. This will be a survey monkey that we'll be sending out to all of you regarding kind of organizational analysis and awareness and looking at your specific needs as we move forward. Then by September 4th, all assessments will be returned. That's my assessment that I'll be sending to you, and begin my recommendations and findings report. By the end of November, all gaps will be completed, and Joy will be having her reports generated. Also, by the end of November, all IT assessments will be completed, and Charlie will begin his work. By early December, we'll be having our interim MTM Consolidated Findings and Recommendations report, and then meeting with DBHDD. You'll notice on the 18th, we'll have a CSB focus group to review some of those results with a specific focus group of community service boards and look at next steps. Then the final recommendation to our Strategic Operations Committee and DBHDD by January, review the report, and then begin planning for phase 2. So those are our milestones for the work that we will do with the department and all of you. So phase 1 consultation support is that gap analysis, the CCBHC certification criteria, readiness assessment, and aggregated results, the electronic health record and information technology assessment, and our strategic business planning with the department. So I'm going to start with the CCBHC readiness assessment and basically give you a high-level overview of what our expectations are here. And then Joy and Charlie will talk about their specific areas of focus as well. So the Georgia Department of Behavioral Health certification criteria feasibility readiness tool. What we have done is we have customized the tool that we use nationally for the state of Georgia to include IDD. And so the assessment tool organizes the ability to address the required activities to meet the Department of Health and Human Services Substance Use and Mental Health Services Administration requirements. There are 6 specific requirements that we have to meet. DBHD and MTM Services have developed a customized assessment that incorporates behavioral health and intellectual and developmental disabilities as part of that. The first section is our feasibility section. That's sections A through E. And so that looks at non-core walls, our ability to move outside of the organization to meet consumers and families where they are. That could be shelters, that could be residential facilities, that could be working with your providers in the community. Trauma-informed care model. How are we implementing trauma-informed care in our organizations? Alternative payment and prospective payment, looking at our costs. How would we look at the costing? How does it cost us for services? And other considerations related to CCBHC. Do we know the state Medicaid rules? The understanding of how your relationships translates into cost. Getting technology right. Our use of telemedicine, which you'll be very good at right now. Clinical quality assurance. Corporate practices of medicine. Alternative payments. What would that look like for us? And then just CCBHC service delivery operational requirements. What do we need to do to make this happen at our local level? The assessment tool is a self-assessment. And with that team, we do need you to be brutally honest with yourself. And a lot of that is based on a 5-point scale, where 1 being a serious challenge, 5 being a not a challenge. So not a challenge means that the workflows, operations are in place, that we are consistently applying that expectation across all your sites, all your locations, no blinking. So really making sure that we're doing this 100% of the time. Serious challenges, we have no expectation here, or you know what, I thought I had a policy on that, but I don't think we're consistent with. That would be a 1 or a 2. And so having ourselves be brutally honest, because that will focus the technical assistance as we go forward. Based on the scores of each of those sections of feasibility and readiness, we're going to move into then a scoring system. So you can see the sample here of a score, where red being high concern and needs to be a rapid cycle change or technical assistance focus. Yellow, we're going to consider changing it based on some of the things we need to put into place. Green, maybe no changes required. So you can see the sample here of an agency, the average score is a 2.1 out of 5. And so the goal of technical assistance would be to help that organization put practices, policies, procedures, workflows, and protocols in place to move you to a 5. That under the attestation criteria for CCBHC, you would have all of these elements in place. And so that's also part of our goal under the governance section or organizational authority, that we will be putting together with you your certification attestation. And so that's a self-assessment that you and your team, your management team, will get together and answer and then send that back to me. I will score it. We'll have individual meetings with you to review your responses. And then from there, we'll be writing up reports. You will get a copy of your report, and then we'll also have an aggregate report for all CSBs. At this point, I'm going to turn it over to Joy Fruth, who will talk about our gap analysis and her work with all of you. Joy?
Thank you. Let me unmute. Thank you, Michael. Again, I am Joy Fruth, and I wanted to start out with, I don't know, a disclaimer or maybe an apology. I'm not sure which, but I live in California, and it's really early here for me. It's not my best hour. So if I seem a little bit sleepy, that's why. But I am excited to be here with all of you, and I really do look forward to beginning this work. I wanted to talk a little bit about gap analysis that we'll be completing with each of your CSBs. But first, I want to tell you a little bit about my background. I am a social worker, first and foremost. I've been with MTM Services now for 10 years. And in that time, most of my work has been helping organizations improve access. In this project specifically, during this first phase of assessment, my focus will be on access. And as you heard from Michael, the reason that we really want to focus on access is because the CCBHC model puts such a high priority on access. As a CCBHC, you must meet specific access timelines. Let me go ahead and advance the slide if I can make that happen. So that is why we want to conduct a gap analysis with each of you so that we can determine your readiness for CCBHC from the aspect of access and how quickly you're able to get clients into care. Yes, it's important as a CCBHC that you meet certain access timelines, but what we also know is that access problems are usually a strong indicator of an unhealthy system. And so we want to be able to learn the strengths, perhaps, the weaknesses, perhaps, in your access system so that we can then make tailored recommendations for each of you when it comes to CCBHC readiness in that phase 2. So that's why. That's why we want to focus on access. How we will do that is through a gap analysis. So I'll talk now a little bit about the what. Gap analysis is a process through which we look for gaps. And what I mean by that is a gap would be a place where we might lose a client's engagement because of how our process is designed. So we will conduct this gap analysis with each of you at your CSBs. And what we'll be measuring is access from first call to first service. I'm going to say that again, from first call to first service. We're not just going to the assessment. We're going to take it through the assessment, our measurement, through the assessment, through treatment planning, and into care. And the reason for that is at MTM Services, we've been working with teams to improve access well before my time, even my 10 years, as Michael knows very well. In our work nationally, we've conducted hundreds of interviews and focus groups with consumers all across the country. We wanted to learn what was their perception of access and how did that differ from what we as staff typically think in terms of when access occurs. What we learned is that there is a very common disconnect. For professionals, most often we consider access to occur at the first face-to-face, which is typically when we bring the clients in. They're going to, at that point, complete consents. Maybe we'll do an assessment at that point in time. That's usually when we consider the client to now be ours. But the problem with that is what we learn directly from consumers in those interviews and focus groups. From the consumers, the message was very different. They would say things like, I didn't call for an assessment. I didn't call for a treatment plan. I called for therapy. I called for meds. I called to get into a group for my substance use. That's what the court mandated. So until I do that, I'm not meeting my obligations. The point being that from the consumer side, most often they didn't perceive access to occur until much further down the line. And so we as professionals need to understand that, recognize that, and if our job is to keep them engaged, then we have to meet their expectations. So when we conduct our gap analysis with each of your teams, we're going to be measuring your access from first call through assessment, through treatment planning steps, and into care. Again, let me see if I can advance this. I seem to be having a problem this morning advancing my slides. So continuing talking about what. So what will you see from your gap analysis? Let's talk a little bit about the deliverables. When we meet with your teams to learn about your access processes, through those meetings, we will document our findings in the form of an access flow chart, maybe multiples. So that will be one of the deliverables to you as leaders. You'll get to see what we gather from your teams in the form of these access flow charts. Now remember, that process or these flow charts will follow clients from first contact through assessment, through treatment planning steps, and into first service. Along the way, we're going to identify inefficiencies, perhaps redundancies, but also the strengths that will make you more prepared and more ready to meet that CCBHC criteria. So the first deliverable that you'll see are those access flow charts. Secondly, we'll also be conducting some measurement. We want to focus on certain indicators of access and measure those along the way. As we learn about process, we will also conduct measurement. The things that we want to focus on in our measurement are these, as you see on the screen, staff hours. So in other words, we want to learn how many staff hours are invested to get a client established into care. We want to look at client hours. In other words, how many hours are we expecting our clients to invest in us before we get them to the service that they are seeking? We want to look at wait days. How long is the wait from first contact to first service, not just to assessment, but again, to first service? And we want to look at cost. In your access, as your access is currently designed, how much is it costing you to get a client established into care? So you'll see a chart similar to the one that you see on the screen that measures all of those 4 indicators. Now, how will we conduct the gap analysis? It'll be conducted in a series of 3 meetings. The gap analysis 1 and 2 will be conducted with your direct service providers, those who have contact with clients, again, I know I sound like a broken record, from first call through assessment, through treatment planning, and into care. So usually that's a mix of administrative staff, those who might handle that initial phone call, clinical staff, those who are going to conduct that initial assessment. It might be a different clinician who then handles the treatment planning if that's the way your process is designed. We need to meet with representatives of all those service types in order to complete the gap analysis. So those first 2 meetings will each be 2 hours in duration, and they will include those direct service providers. We ask that you exclude leadership from those first 2 meetings. And the reason for that is what we've learned over the years is if the boss is in the room, what we tend to hear, the answers we tend to get skew a little bit more toward how things are supposed to be and a little bit further away from how things really are. And in order for us to make the best recommendations to get closest to that CCBHC model, we really need to have an accurate picture of what's going on the ground. So we ask you to exclude leadership from those initial 2 meetings. Our focus, our service line focus, will be in the areas that are particularly relevant to the CCBHC model. So mental health, substance use, psychiatric medication management, and obviously our intellectual and developmental disabilities. We want to measure access to those particular services. So those are the relevant staff that we need in the room. And lastly, the last meeting in the series is a gap review. This is when we now, instead of meeting with direct service staff, we want to meet with you as leaders. This is our opportunity to share with you what we've learned, walk you through the deliverables, and start to talk about our findings and our recommendations individually for each of you. That's a 1-hour meeting, and that should be scheduled at least 1 day after the last gap analysis, the gap 2 meeting with your staff. So you'll see contact coming from us very soon about scheduling. We want to get these going as quickly as possible. As you can see, it does take 3 meetings, and it might be a challenge for each of you to arrange times when all those sort of disparate staff are available to do an internet meeting, but you will see contact coming from us soon. And with that, if you have any questions, please do enter those into the chat box, and we will try to get to those later as I understand. And now I will turn it over to my colleague, Charlie Grantham.
Thank you, Joy. Let me see if I can figure out how to make the slides go myself here. Okay. So first of all, again, my name is Charlie Grantham. I'm an IT and process optimization consultant with MTM Services. A little history about me. I have spent my formative years in the hospital IT business, primarily about 20 years doing that with some of that being IT director at a hospital with a skilled nursing facility and physician practices and that sorts of thing. But the last 3 years, I've been working with MTM Services and been doing a lot of work around assessing practices, much like yourself, to really find out, where you stand in the technology sort of continuum. So with that said, and with, CCBHC or CCBHC Plus, like we're sort of looking at here in the state of Georgia, are we ready for that road ahead? In many cases, sometimes maybe we're not. Maybe we've still got that T-Model Ford there trying to get us down the road. Because really what I see out there across the country is that the technology waterfront can be very wide. Maybe not as antiquated as the guy there on the left with his old IBM systems over there, but maybe inching closer and closer to that care in your hand model, much like we're doing now with more and more of this, sort of distance treatment that we're able to do with telehealth. I saw an interesting post the other day on some social media about, I didn't get a chance to put the sort of the meme into our presentation here. It asked, what was the driving force between technology change in your practice? Was it the CEO? Was it the CFO? Or was it COVID-19? I think many of us would be checking the final box there. So about our IT work that we have together, one of the first things I wanted to talk about was, sort of what the flow was and what the time commitment from you would be. For the IT assessment, we start with a 1-hour kickoff meeting that would be that would include sort of your senior leaders along with your technical staff, maybe if you have clinical informatics or those folks that act as sort of the translator between clinical and geek. Those people would be important to have in that kickoff meeting. After we do a 1-hour kickoff meeting, then we move to a user survey, which is for the rank and file of your practice. Much like Joy was speaking about earlier, we like to survey the users to get their perspective of how systems and things are working from a technological standpoint. Again, sometimes the difference between what management thinks and what the rank and file do can be a little different. After we have a little time for that user survey, then there's a virtual assessment day. We'll talk a little bit more about what is involved with that, but it's usually split between technical and clinical folks and really going through and baselining some of your systems. That all comes back into a final report as deliverables, and then I always bookend with another 1-hour meeting for the review of any of the findings and recommendations for your particular site. So all in all, the time commitment is 2 1-hour meetings with senior staff, and then we'll talk a little bit more about the on-site day as we get there. So the first step is really that customer survey. We want to ask the people that use the system, because the system really touches, and technology touches many of the different areas of your practice. It's not just the EHR, it's all the other systems that play too. Is your technical support there? What sorts of technical challenges are your staff having that maybe you're not, because you work in your office and not remotely, for example. So after the survey, folks have a chance to answer that. We move to, again, that on-site day for assessment. Well, it used to be an on-site day, but as you might imagine, we will be doing that mostly virtual, is my guess, as we move forward. But as far as the day goes, the way that would sort of break out would be a kickoff meeting about 30 minutes in the morning with your senior leadership, sort of the members of the people that were on the opening phone call. Then we would have a morning session, say, with your IT staff to sort of geek out, look at the nuts and bolts, what makes your practice work from a technical standpoint, and really document that current state. Then usually in the afternoon, I meet with clinical management and staff to really find out what the clinical processes are, what the processes that you go through to make changes to your system, all that sorts of things. What are the big hurdles there? I also want to talk with the back office people, getting the bills out and compliance and all those other pieces that touch the EHR. It's important to understand what their workflows are and if there are any hurdles for them. Then usually a 15 or 20-minute wrap up at the end of the day with just the senior leaders to go over the first impressions of the day and some initial findings. So all in all, I try to have as low impact a day of assessment as possible. People can come in and out of these sessions and, with some order, try to be as loose as we can so that we don't have a great impact to your daily practice. But as far as the IT assessment goes, I'll be looking at a lot of different things. From the way your network is designed, to your servers, to how you connect to the internet. What sorts of backup do you have? What is your disaster recovery plan? All those things will play into your ability to be a successful CCBHC. You've got to have the systems and the guts to really make it work. We'll also be looking at your EHR, looking at those workflows. How many clicks does it take? But also about reporting. Reporting is probably one of the most important pieces of the CCBHC model. We not only have to be able to collect the data, but we have to be able to report it. So looking at those capabilities will be key. Nowadays, it's about mobility, looking at the other features and that sorts of thing of your EHR. And then, how are you now, or how are you poised to be ready for that integrated care capability? What sort of interfaces are you doing now? Are you working with your primary care providers or the hospitals that are near you to know when people get referred to you, that sort of thing? So by using these sort of three different areas of assessment, both the IT assessment, the EHR, the other supporting systems, and your users, that allows us to arrive at our ultimate report, which would include that assessment detail and the detail from the customer survey, and then consolidated into a summary report. So that's it for what the IT assessment looks like going forward. Please enter any of your questions into the chat window, and I think we'll be going to those at the end. So I look forward to this work with all of you. And now I'll pass it back over to Michael.
Thank you, Charlie. So as you can see, team, there's a lot of assessment opportunity here to really look at the operability of your organization to really truly become that new provider type. It's no longer business as usual in the CCBHC world. And as part of that, that also means that as an organization, we're also looking at some of the strategic planning that we've been doing and will continue to do with DBHDD. Our structure is that we've got a CCBH steering committee, which functions and approves any recommendations from the Strategic Operations Committee. The Strategic Operations Committee functions and defines the scope of work, provides oversight for the strategic business planning for DBHDD to really look at those components of becoming a CCBHC. We're looking at a finance and alternative payment reform team, a quality compliance and outcomes team, information technology and outcomes and reporting team, organizational authority and network adequacy, and accessibility and availability care coordination and scope of services and staffing. So these kind of pull all these components into place as we look at kind of pulling down the information from the assessments, and then where do we need to go as a system of care to really truly meet the expectations of becoming that new provider type that also includes our folks with intellectual and developmental disabilities, which, as Charlie said, and I think coined it very well, CCBHC Plus is really adding and being more inclusive with the individuals that we're serving. So at this point, Monica, I'll turn it over to you to lead off some questions and responses.
Thank you, Michael, Charlie, and Joy for that very thorough presentation. So far in the chat, we only have one question. The question is, how will this affect the current way IDD individuals are entering services? Will everything continue to go through the intake and evaluation teams? We are nowhere near being able to address that question. I don't believe we are. When you hear us talk about the plus part and us wanting to be inclusive of IDD, we're working through now what does that look like? What part of the population in IDD does that look like? We're not necessarily trying to turn it over on its head, but really just trying to sort through, with this model, what parts of that population make sense. So that's what we are, that's the space we're in right now. Ron, I see you. Did you want to add anything?
Monica, no, you said it well. And I just want everyone to recognize that DBHDD, we are entirely focused on including IDD in the safety net. And as Monica said, we will work through what exactly does that look like. So current processes will continue for now, but as we go forward, we'll provide more information as we talk this through.
And it's a similar question related to IDD. Will support coordination companies be involved in this project? And I think the answer is that's to be determined, right, Ron?
That's correct.
And then I see, how does the CCBHC model impact our current CSBs, more specifically, how we operate? Does this require, or is the expectation of implementing this model require mergers or consolidations among the existing CSBs? So I think I want Michael to weigh in on this one, but essentially from the presentation, one of the big takeaways is that the CCBHCs is a new provider type. And if you kind of do a little bit of further digging into what that model looks like beyond what Michael touched on today, there's lots of literature out about what the model is. I think it will address some of that. It definitely would require different expectations and implementation to get to the model, but we're not there yet. We're in phase one. And so phase one is the data collection. It's all of what you just heard presented from Charlie, Joy, and Michael, the assessments. We're in the information gathering stage. We're in the planning phases. So we're not near implementation. And so a lot of those questions we can't answer right now, but we are trying to gather the information so we can make informed decisions about what would it take and what would it look like to transform our system to be inclusive of this model. Michael, is there anything you want to add to that?
I think that's going to have to be a planned decision related to whether there's consolidations or mergers. When you think about your organizational capacity, where do you fall in your operability? If an organization, I know what we've seen nationally, is that if they're going after a CCBHC and they can't meet the expectations, then do they partner with a CCBHC to really make that happen? I remember talking with one potential grantee earlier this spring, and it was very clear that based on their infrastructure, their organizational structure, their IT capabilities, their access, that they were probably better off being a contract provider of a CCBHC than actually going after becoming a CCBHC themselves. Because we have to be able to, there's certain core criteria that you have to provide, and you have to provide it well as part of that attestation. So I think the easy answer to that is probably, depending on your scoring and kind of where you're at organizationally, that may be a yes for you personally as an organization to really look at your capabilities and capacity. That we know that I know some of our work in other states, when we were the leads in other states is that they were beginning the original planning grants, one particular state said, okay, everyone in the state can be a CCBHC. But what became very clear is that not everybody met the criteria to become a CCBHC. So they really had to sort of make some decisions about who could be a CCBHC and who is going to remain a contract provider at the state level. And so there's some organizations just really couldn't make the cut to become a CCBHC. And so they opened up the arms and said, everybody, you can be a CCBHC, but when it really got down to it, many of those organizations self-selected out. It was too much of a heavy lift for them to be a CCBHC.
Thank you, Michael. So there's a couple of questions that are similar, so I'm going to try to group them together. It's about CSB involvement in the process. So there are different phases, levels, processes, and points throughout this work. We're going to be in this for the long haul. We're at the very beginning, and so one of the questions is who all makes up the committees that was on the slide that you have put up, Michael, in terms of how we're organized. I'm not going to list out all the names. I don't have that right in front of me, but it's a lot of people, and they are internal and with MTM. So one of the things that we'll be talking about and trying to explore beyond the things that have already been identified in the timeline of activities, there were specific points in which we want to target and engage CSBs beyond the level of engagement that you're going to be involved in with collecting, gathering data, and completing assessments. So as the commissioner stated earlier, that is one of the best ways to provide input into this process, because remember, in this phase, we are information gathering to try to just wrap our head around what is out there. How close are we even to being able to transform into a different provider type? Who can do that? And so just, I think, remembering that we're so far from implementing, we are trying to gather information. So at this point in time, the best way for CSBs to be involved and to help is to participate in these activities, because it's a lot of that we are asking, and it's a lot of information, and that's what we need to focus on, is really trying to pull that information together. I will go ahead and take the time to say this. I was going to include it in kind of some next steps, but it's appropriate now. We know that there's going to be questions that you're going to walk away from today. You're going to have the best way we've decided to manage those questions and then act accordingly. It may be that the questions that come in trigger us to do something or pull in the group or do something, but it's hard to outline that right now. But what we do know, and I've talked to Robin from the association, and I thoroughly appreciate her support and partnership on this. And what we've agreed, we worked together in the past to try to have Robin collect questions in whatever format you guys may come up with. I don't know if it's when the CEOs meet through the association, if it's other groups, however y'all decide to do it, but to bring forward questions, bring forward ideas about this process, but remembering that we're in the planning and information gathering stages, so that information can be consolidated. It can be given to Robin. Robin would give that to me, and then I would be bringing those things back to the strategic, the operating group, and then the steering committee that is structured internally. But those questions and some of the comments may trigger an action on our part. So a way in which we haven't thought about maybe engaging for this part of the process, it may trigger us thinking about a different way to do that. But right now, I want to anchor back to what the commissioner said around there's going to be a lot of acts, and you heard the walkthrough of that today. So if we can focus on us getting good, accurate data that will help drive what we need, that is what is most important for us right now. And that data is coming from you. So it's very critical. So I want us to just kind of remember that.
One of the things I'm going to jump in, Monica, if I can, part of Charlie's work is also, there's also going to be some opportunity for the DBHCD. Charlie's going to be doing an assessment, an IT assessment of the department as well, of their functionality. So this is not just a CSB kind of push. This is really looking at a system-wide orientation and review. So Charlie's going to be doing some work at the state level as well, because there's state reporting requirements and the ability for the state to receive information from all of you and report out to, should we go after, should they open it up to states where Georgia can actually go after some state funding or SAMHSA funding? Right now, that's not available to states. So we're looking at, how we can look at this differently within the Georgia model.
Okay. Thank you,
Monica?
Michael. Yeah, I'm here. I'm scanning. There's a question about fund source. I kind of spoke to a little bit what you just said, and we're not there yet.
Right.
Beyond what you just touched on. So, does this work line up, or how does it line up with Governor Kemp's study group on behavioral health? We definitely believe that it lines up. Anything to improve our behavioral health system and our network and strengthen the system, we believe is in alignment with that work. It doesn't interfere with that from our perspective. I think I've hit all of the questions. I'm scanning. I'll give folks a little bit more time to enter questions to see if there's anything else. Okay, well, not seeing any additional questions in the chat. Like I said, for next steps, again, I know you're going to have lots of questions throughout the process. Questions related to the actual assessments, and when you get your contact, your outreaches from Michael, from Joy, from Charlie, they'll obviously be your best contacts for questions about the assessment, questions about the process. You do not need to go through me or DBHDD for that. If you have concerns or that are beyond that, then of course let us know. But if you just have questions about the process, please utilize the MTM team for that. And then general questions beyond that, please do already work with Robin, and I'm sure Robin will communicate with the CSBs on whatever structure you guys decide to implement. But Robin will be my point person and how I stay connected to the network. It's just easier to manage versus trying to field 100 questions. So if we could try our best to work together in that way, that would be great. And then I saw the question that just came through. Michael put it up. He had it in his slides. So the question, for those that can't see it, what other states have already implemented the CCBHC system? And so, Michael?
All of those states that you see highlighted in blue have already implemented CCBHCs within their states.
And so to clarify, so Georgia is blue, but that's because there is a provider in Georgia that's a CCBHC that recently got the last SAMHSA grant that was out. And I think it's important to know, too, that originally these grants were only eligible for states to apply. And for whatever reason, the last round or two were targeted to providers. And so it's very difficult for me, from my perspective, to implement when the state hasn't, to have an agency that has. And so Georgia's blue, but we're wonky because we don't have it implemented in a statewide type of capacity.
And if you think about those, like Iowa or Kansas, the state is now getting on board, and working with providers. So technically the providers kind of jumped or leapfrogged over the state and became CCBHC providers. Now the state is working with those providers in those states to help move forward to that certification process. because that's one of the challenges is if you don't have the state engaged in this process, the state is the one that technically has to certify the provider as being CCBHC, not necessarily SAMHSA. And so when you when you kind of leapfrog over the state, then that creates that there's no way to validate or certify the CCBHC from the state level. And then we also don't get the data metrics, the state required data metrics as part of that.
Someone asked, as a CCBHC, will this open up additional SAMHSA grants to CSBs? So I may be interpreting the question wrong, so I'm answering the way I think I'm hearing it. If SAMHSA offers grant opportunities for CCBHCs, they haven't put out a new round, and it's for the state would obviously apply. And then if they do it where providers can apply, because we are exploring this process, then, you know, a provider may choose to apply. So it's kind of hard to say because I don't know what I'm not quite tracking the logic and how they're rolling out the grants, but yeah, so. The recording for today's meeting will be generated and ready for viewing next week. So for those that do need the video, that will be available next week. All right, so I don't see any other questions. I want to thank you all again for your time and for your participation and for your attention today. I know it was a lot to absorb, a lot of information. The good news is we'll be having lots of conversations. I promise you. And so if people are still waiting for me to say exactly how many times and how often and who all will be talking, we're going to be talking a lot. It's obvious from the level of work that has to happen that we have to do this together, and that's our intent. So with that being said, I'll go ahead and thank the participants for participating, and thank you, MTM team, for your partnership, and for Joy, I am so sorry. I did not know that you was in California. I felt so bad, but I appreciate you joining us and looking bright-eyed as ever. So I really appreciate that. Thank you, guys. So with that, thanks to the commissioner for kicking us off. Our other esteemed leader, Jeff Miner, has been on today. So thank you for taking the time, and for all the team members at DBHDD that are working on this huge project from across the department. It is a huge collaborative operating internally to try to get this right out the door. So really appreciate those team members that are also on this call and are putting in a lot of work. And with that, I will go ahead and conclude this meeting. I hope you guys have a great rest of your week. Thank you.
Thank you, everybody. Stay well.